I'd like to talk to you about embracing a new normal of innovation, radiation oncology advances in precision diagnosis and treatment for prostate cancer. When we think about prognostic biomarker in radiation oncology, can we identify radiation oncology patients who have more aggressive or less aggressive disease? I'm going to talk about two specific items today to advance prognostic capabilities in prostate cancer risk stratification. The first being using multimodal deep learning with digital histopathology, and the second being using targeted precision imaging for the definitive and metastatic directed therapy. First, using multimodality deep learning. Let's start with an introduction to a multimodal AI artificial intelligence architecture. Indeed, the field of radiation oncology and prostate cancer has been predicated on using pathology, i.e. the Gleason score. But we can couple this with artificial intelligence with the hope of improving diagnosis, prognosis with long-term outcomes, and the prediction of treatment response. MMAI is leveraged to develop a model that outputs predictive and prognostic results. Using clinical trial data, acquiring the appropriate imaging, and making that digital pathology, coupled with clinical data from clinical trials. We can couple the clinical data features with imaging data features to predict therapeutic benefit and have a prognostic risk score of outcome of interest. A technique built by Artera AI created a prognostic biomarker model based on prospectively randomized trials of over 5,000 patients with low-risk prostate cancer on radiation therapy clinical trial. Here we see the trial summary. RTOG trials were used to train this artificial intelligence biomarker, which is powerful due to its lack of bias and meticulous outcome collection. Now, development of an MAI tool was not easy. Artera used slide digitization and data collection of the clinical data and outcomes that you see here. And it trained its model on 80% of the data and then validated the model on 20% of the data. Now, indeed, clinical trial data was used to train and develop the Artera AI prostate test. Here we see 5,654 patients and over 16,000 slides were used, with a median follow-up in these trials of 11.4 years to create accurate clinical and long-term outcome data. So again, addressing the prognostic AI biomarker question, can we identify patients who have more aggressive versus less aggressive disease? The Artera AI model can further stratify patients within a given NCCN risk category. Now, the NCCN risk categories were designed and built off the groups first proposed by Anthony D'Amico in 1998. It was built around a biochemical failure endpoint, but that's complicated because not all men who have biochemical failure will ultimately require additional therapies. Additional endpoints such as metastasis or prostate cancer-specific mortality are maybe more relevant when risk stratifying patients. AMMAI improved risk stratification can optimize treatment intensification decisions in localized disease. Here you see MMAI prognostic model outperforms NCCN risk grouping across clinically relevant endpoints, whether it be distant metastasis, biochemical failure, or even overall survival. This was the first and only AI-derived prognostic biomarker test to be recommended as a risk stratification tool in the NCCN clinical practice guidelines in oncology for prostate cancer. So moving on to another question. As a predictive AI biomarker, who will benefit from hormone therapy, a short-term androgen deprivation, and who won't? Well, using a development of predictive biomarker in the setting of short-term androgen deprivation, taking the NRG biobank training set with these 4 trials, looking at patient data, clinical data, and digital pathology and imagery, AI was used to predict short-term androgen deprivation benefit and validated within the NRG RTOG 9408. This analysis of biotreatment interaction showed here that MMAI predictive biomarker identifies patients who will benefit from treatment intensification with short-term androgen deprivation. On the left, we see the significant separation occurs on the biomarker positive group, and on the right, you see a very limited separation within the biomarker negative group. Indeed, there can be prognostic and predictive biomarkers that can both influence treatment intensification decisions. So you have your patient you're concerned about. The prognostic test shows that in the setting of an excellent prognosis, treatment intensification is unnecessary. However, in the poor prognosis patient, treatment intensification is desirable with a predictive test on adding ADT to radiation therapy. Here we see the biomarker. If it's negative, again, the ADT has no benefit, and you consider other alternative therapies. But if there is a biomarker positive, you believe androgen deprivation has a benefit. Thus, improved by prognostic risk stratification can optimize treatment intensification decisions in localized prostate cancer. In this presentation done by Jonathan Tward at Astro in 2022. So what does the Artera AI prostate test look like when you're looking in front of a patient? Well, as you can see, this is recommended NCCN guidelines based on level 1 evidence from prospective randomized trials to inform personalized discussion of an individual's risk of developing metastasis and PSM. It can help both the patient and the physician craft therapy once they understand the benefits and their side effects of the treatment choices. So let's shift gears and now move towards talking about using targeted precision imaging for definitive and metastasis-directed therapy. I'm going to talk about the seminal work led by Dr. David Crawford, and I was fortunate to be a co-investigator and a co-author of this, called RADAR-6, which looked at targeted precision imaging, or TPI, with molecular targeted imaging, also known as MTI, in patients with prostate cancer. And again, this is known as RADAR-6, the latest update of the RADAR prostate cancer guidelines. And it was published in the inaugural issue of the Journal of Urology's Open Plus edition. Let's start with RADAR-6's guidelines for newly diagnosed prostate cancer. When we think of the RADAR-6 guidelines for molecularly targeted imaging in newly diagnosed prostate cancer, we see a movement from our previous guidelines, which looked in RADAR-1 at conventional imaging, and our RADAR-3 guidelines at next generation imaging, to RADAR-6 guidelines, which are looking again at targeted precision imaging. When we look at this, we're looking at patients who should get it are unfavorable intermediate risk, patients at high risk or very high risk of prostate cancer, plus or minus conventional imaging. It's in patients who are inconclusive in prior conventional imaging in which there is a high clinical suspicion of metastasis or local regional disease or risk of nodal metastasis. Who else should get targeted precision imaging? Patients who have an elevated molecular marker such as Decipher or Prolaris, or maybe even Artera AI as this develops. In patients' populations with genomically diverse high risk. Now, the trials that predicated that work, as you can see here, to determine the safety and diagnostic performance of TPI using PET-CT, you can see where Osprey and Lighthouse, using these two agents, go by the trade names of Polarify and Posluma. Now, they were unique individual trials. They looked at the toxicity profile that was well tolerated in patients with prostate cancer. They demonstrated high sensitivity regarding distant metastatic prostate cancer with excellent specificity regarding pelvic lymph nodes. They had comparable baseline characteristics for both study cohorts, but they had nuances, and you can never really compare two trials together. But when you look at the trials, you see a larger number of evaluable high and very high risk patients in the Osprey cohort A trial using Polarify compared to Lighthouse using Posluma. And again, there was a lower AE rate reported in Lighthouse, which used Posluma, although the reporting period was 5 days versus Osprey of 7 days post-dose. When we think of moving on to our RADAR-6 guidelines for patients with biochemical relapse, when would we use this? Well, again, moving from 1 to 3 to the RADAR-6 guidelines, the recommendations for targeted precision imaging are for the patient who metastasis-directed therapy may be considered, that TPI is preferred over conventional imaging. For the early and accurate identification of sites of disease that can lead to more anatomically directed therapy, to optimize outcomes that can be facilitated by early detection of the sites of recurrent disease. Again, these trials were done to determine the diagnostic performance of TPI in patients suspected of recurrence of prostate cancer. These trials were Condor using Polarify and Spotlight using Pasluma. Again, they had their individual nuances. Condor used a CLR as a single primary endpoint, with CLR including 5 regions. Spotlight used CDR with region level PPV as co-primary endpoints, with regional level PPV including 3 regions. With respect to Condor, the primary endpoint was met, and there was a change in plan management data included in the trial. In Spotlight, the CDR primary endpoint was met, although the regional level PPV endpoint was not met, and there was no change in plan management data. Moving on to the M0 castrate resistance space. When we think of TPI recommendations for appropriate use criteria, TPI is recommended in men with PSA progression, wall and androgen deprivation for biochemical recurrence if metastasis-directed therapy is a potential option. Otherwise, conventional imaging can be performed to verify the M0 status. Patients whose disease is detectable only by TPI and not by conventional imaging should generally not be treated as M0 because this approach is most consistent with level 1 evidence. The role of TPI while on therapy for M0 for patients with systemic therapy on M0 who had TPI as a baseline for the M0 castrate resistant status, imaging should be repeated at least annually at the time of PSA recurrence. No PSA cutoff for repeat imaging as yet because PSMA TPI can be positive even at low levels. And for patients treated with local therapy in the M0 space who had TPI as a baseline for the M0 castrate-resistant prostate cancer, TPI may be repeated with 4 to 6 months to document the response to therapy and assess for new metastasis, and then be repeated annually as above. Moving on to obviously a very important space, the M0 castrate-resistant space. We have different settings for the disease detection. For initial staging, TPI is recommended for the staging of M1 castrate-resistant prostate cancer if it's likely to affect clinical decisions. For treatment eligibility based on phase 3 vision and therapy trials, PSMA PET imaging can be used for treatment selection of PSMA-targeted therapies. And fluciclovine can be obtained in patients with treatment refractory M1 castrate-resistant prostate cancer to inform subsequent treatment strategies. For treatment response, patient response criteria are lacking for TPI. TPI should not be used alone to make treatment decisions regarding discontinuation in the context of M1 castrate-resistant prostate cancer. In the M1 space, we're obviously very interested in metastasis-directed therapy. Local therapy, such as what I do in radiation oncology, have been primarily used for palliation of symptoms. But beyond palliation, radiation with such advanced techniques as stereotactic body radiation therapy may also impact the course of metastatic disease by altering the natural course and by be potentially curative by limiting disease burden and preventing further spread. I was one of the co-authors, one of the initial papers on stereotactic body radiation therapy as both rational and reasonable as an approach. Again, there's a unique radiation biology of prostate cancer with a perceived increased biological effectiveness of large fractions caused by the alpha-beta radio differentials for prostate cancer. The use of large doses of radiation per fraction potentially provides a unique biologic effect on both the tumor and normal tissues. I was fortunate to publish this paper back in 2011 with Bob Timmerman and Bill McBride and others. And when we looked at is that the idea that radiation therapy delivered with advanced techniques such as SABR, stereotactic body radiation therapy, can induce cellular expression of MHC class 1 molecules, adhesion molecules, co-stimulatory molecules, heat shock proteins, inflammatory mediators, immunomodulatory cytokines, and depth receptors. Moving on to imaging discordant. What do you do about the patient where conventional imaging is negative, but the molecular targeted imaging, such as PSMA PET, is now positive in newly diagnosed metastatic prostate cancer patients? Well, as you can see here, TPI is redefining advanced metastatic prostate cancer with men with positive TPI, representing a wide spectrum of disease and heterogeneity. Clinicians have now a number of therapeutic agents and interventions in our armamentarium. Most approvals were, though, based on conventional imaging. Earlier therapeutic approaches tend to improve survival and outcomes, and TPI offers an opportunity to implement metastasis-directed therapy, as I just mentioned. We published RADAR algorithm guiding treatment decisions based on patients with localized disease when they have discordant or concordant imaging. On the right, we see here what would happen if we had discordant results. And again, in the oligometastatic or disseminated setting, you would treat those patients as metastatic according to radar guideline. I hope you can see that we're trying to embrace a new normal of innovation using exciting techniques such as multimodal deep learning with digital histopathology and using targeted precision imaging for definitive and metastasis-directed therapy in the field of radiation oncology. And we believe this will enhance radiation oncology advances in precision diagnosis and treatment for prostate cancer. I'd like to take a moment and dedicate this talk for my father, Howard Finkelstein, prostate cancer survivor who passed away this year due to COVID. I want to thank the meeting for allowing me to speak here today. It's been an absolute pleasure.